on the right side of the screen is the blood side of the screen. Down the middle, that membrane is a dialysis membrane, and you see various holes in that membrane. They're pores. And on the other side of the dialysis, the membrane is the dialysis bath. And through the process of dialysis, it means that we run your blood on one side across a membrane in the middle with the dialysis bath on the other. And the whole idea is to filter those metabolic toxins and small proteins from the blood side into the dialysate side, and that dialysate washes away. So it's a very simple process, which actually hasn't changed much in the last half century, believe it or not. Thank you very much. The principle of diffusion is exactly the same, so that these molecules that should no longer be in your blood, that your kidneys normally filter, they are washed away in the dialysis fluid through these holes. And these holes are only so big so that they cannot pass red blood cells, so the red blood cells stay in your blood, but the toxins can go out, and other large molecules such as phosphate also tend to stay on the blood side because they're very large. So that's the process of diffusion that all dialysis modalities use. And ultrafiltration is simply a similar process in that there's the membrane right here. You see the pores right here. And this side is the blood, this side is the dialysate. If you have too much water in your blood, we just increase the pressure on the dialysis machine to push more water into the dialysate and take that away. So that's ultrafiltration. So the process of diffusion and ultrafiltration are separate processes, but they can be complementary. So when we write your dialysis prescription, we write the time that you need to stay on the machine, the length of treatment, the times of treatment, and as well as we just specify how much fluid needs to be removed per treatment, and that's your dry weight. And Dory was talking about this morning the measure called KT over V. Most of my patients in dialysis know of this as the URR. Does that sound familiar to you? The urea reduction ratio. It's a very similar number. They mean the same thing. So that's why you have not heard of KT over V. They're the same sort of measure. So that's what we use in our unit today. So all of dialysis uses a process of ultrafiltration and or diffusion, either separately or in complementary to each other. So the dialysis modalities that I'm going to talk about today are you can undergo hemodialysis or peritoneal dialysis. These are the two main differences. And under hemodialysis, you can do in-center treatments via conventional dialysis, 3 times a week dialysis, or nighttime dialysis. Several units around the city have nocturnal hemodialysis. Or you can go on home dialysis, and there are conventional and nighttime modes of that as well. And all of these are associated with different benefits and drawbacks, and I'm going to go over each of these in turn. And please feel free, this is supposed to be an interactive conference. Please feel free if you have any questions to voluntarily discuss those while I'm talking. Now currently, this is the latest data from the ESRD network, and currently the majority of patients, the number of ESRD is about 340,000 right now in the United States, and the majority of those patients are on hemodialysis, standard in-center hemodialysis, and this little white bar here is home hemodialysis, and the gray bar up here is PD and other forms of dialysis. So the majority of patients by far are on in-center hemodialysis because that's the modality that has been around the longest. And you can see there's a significant number of patients that are undergoing transplantation, and there is a separate discussion for that. So most patients actually can do any of the modalities for dialysis. Modality selection is determined by your medical issues, your other medical problems, patient's social circumstances, and the wishes of the patient. And the choice can have a long-term impact, as Dory suggested this morning. However, the selection is complex. When you have chronic kidney disease and you know that you're headed toward dialysis before you have to start, you are flooded with so much information, it's mind-boggling. It's actually incapacitating at some points. And our job as the medical directors or as nephrologists or nurses or healthcare providers are to provide you with enough information so that you can make an educated decision on what type of therapy you think would be best for you given your situation. And I think that's our responsibility to help you make that decision. You do not have to make it yourselves. But many times, many hemodialysis patients, once they choose in-center hemo, are resistant to changing anything, and about 99% of the patients in America today stick with the modality that they first started with. So if you start on home or in-center hemodialysis, the chances are very high that you will stay with in-center hemodialysis. It's difficult to make changes, and honestly, a lot of doctors and healthcare providers lack experience with other forms of dialysis, so that they're not inclined to try and educate you about, for example, peritoneal and home hemodialysis. Now, with my dialysis unit, and we're a nonprofit organization, Independent Dialysis Foundation, we've had the initiative in the last 2 years to take all of our patients during their care plan meetings and try and provide them with an opportunity to learn more about the other forms of dialysis. And they can say yes or no, but we at least give them the option of learning more about other forms. And I think that's, again, something that should come from the healthcare provider team, no matter where you start. And we should provide better education pre-dialysis so you can make a well-informed decision. We oftentimes, a lot of pre-dialysis education will yield more frequent home or peritoneal dialysis. And I'll show you why in a minute. And it reassures the patient, the better educated they feel more suitable to be able to potentially do it at home. Now, there was a survey that was published this past year that asked several people if you had to choose a modality, you were not on it yet, if you had to choose my modality, would you choose to do conventional in-center dialysis 3 times a week in a dialysis clinic? And interestingly, as this slide shows, when they asked doctors this question, the majority of doctors, nephrologists, the majority here would choose home hemodialysis. Okay, interesting. And we'll come back to why in a few minutes, home hemodialysis. And when they ask patients what their preference is or why they would not consider other modalities other than hemo, this light-colored bar here is newly started patients on dialysis. The darker brown bar is those patients on dialysis for greater than several months. And when the majority of patients were asked, were you told about alternative dialysis options that are performed at home? Over 80% of them said yes. Did you attend a dialysis options clinic? Only up to a third were offered that option. And did your nephrologist talk to you about home therapies, or did you hear about home dialysis in your clinic? About 50% of them said yes. And I want to remind you the importance of this is that a better educated patient can make their own decision. And at my very last slide, I will tell you why that is critical to you. Secondly, a lot of patients, when asked why they would not consider other options, and a lot of them said they prefer in-center hemo for whatever reasons. They have their reasons. They feel incapable of doing it at home. They have family or home barriers to doing dialysis at home, and their medical condition would preclude them from doing it at home, or they didn't want to make the time commitment to do it. Finally, what would be make you more likely to switch to a home therapy? Almost half said nothing. They wouldn't even consider switching. We don't even have to talk about it anymore, and that's good. If they received help or had a better or prospect of having a better quality of life, some would consider more strongly the option. But again, 99% will stick with their original therapy selection. Now, just to go over the different forms of dialysis, and most of you are on dialysis, you already know this, But this is a typical hemodialysis machine. Here's the machine right here. Here's the kidney right here, the filter right here, which we call a kidney, the blood chambers, the dialysis tubing going to the patient, and then the venous line going back into the machine to filter the blood away. That's a standard hemodialysis machine or operation, and you have various forms of access. Now, the national standard and initiative is to have more patients have fistulas. That's why the NKF and other programs are pushing fistula first, because fistulas, which are a surgical way to turn your vein, here's the vein going to the hand, here's the artery taking blood to the hand, vein going away, it creates a loop in the wrist. The seminofistula is this one. It creates a loop, and after a time period, this loop, this gets mature, and the walls thicken, and we can hence stick the dialysis needles in here and get a better blood flow. Grafts are also used when the patient's native, meaning the vessels that you were born with, cannot take a fistula, and occasionally we have to resort to catheters when dialysis starts urgently, or for some reason a patient is unable to tolerate either one of those or is on the waiting list to get either one of those. So does anybody have any questions so far? This is, I think you're all familiar with the standard dialysis treatments. So what factors favor in-center hemodialysis? And those are supportive network, major illnesses. Patient who has a lot of medical illnesses, not just end-stage renal disease, such as diabetes or lupus or high blood sugar, that's diabetes, sorry, other comorbidities, tend to do better in centers. Those who are severely obese, they lack family support or hygiene, they tend to do better at the centers where the staff can take care of them and take care of their needs. What factors will tend to oppose conventional dialysis in-center? Those are lack of vascular access. So if you cannot get an arm or a thigh graft or fistula or catheter, and you have to do it in the abdomen, that's obviously for peritoneal dialysis. And a lot of those patients are like the patients with end-stage heart disease they have such poor blood flow throughout their body that they have to get it through their belly to make it a more smooth process. Those with large weight gains tend to do better in-center because they can be monitored more closely. And those patients who live very long distances to hemodialysis centers, obviously mobility is not going to help there. So that's an issue for in-center dialysis. But the pros of in-center dialysis are numerous. And they include, you have 4 days off per week. They're trained staffed. The 4 days off includes some downtime. There's trained staff to take care of you. During the downtime, you can read or play on the computer, sleep. You are a partner in your own care, a partner, you're not responsible for your own care. You can set up your travel in advance if you want to go to a different city, for example, or you want to go out of the country. You can schedule hemodialysis in that city, in that destination. You have access to the surrounding doctors and teams. These centers follow guidelines put forth by the Centers for Disease Control, who are very strict about regulating sterility measures. And for those of you in center currently, you often see using the protective equipment, and that's to measure to protect the patients against bacterial infections or viruses. And another thing I want to emphasize is that a lot of patients, just like the fellowship, there are numerous successful 12-step programs in this country upon which the foundation is the fact that the patients in those fellowships have a single disease. Doesn't matter what lifestyle you live, what your background is, they have the same disease, and they have to get this certain treatment to sustain their life. Whether it's dialysis, whether it's cancer, whether it's alcoholism, whether it's a ton of other things. And the fellowship is one of the glues that helps hold them together. And so some people, that helps to give them a reason to go on, and that's important. The cons are you have to follow fluid and water restrictions. Sometimes the staff are too busy. It's somewhat uncomfortable being in those plastic chairs. and you have to have the needles and access. A lot of people feel washed out after a treatment, and there's no spur-of-the-moment travel. So that's hemodialysis, in-center hemodialysis. And I'm going to transgress for a minute and talk about a concept that's called integrated dialysis care, which means using hemodialysis and peritoneal dialysis at various times to complement each other. And what this modality does, if you're just getting ready to start my hemodialysis, is it takes advantage of the benefits of early peritoneal dialysis. And I'll show you that. Why is peritoneal dialysis advantageous early in the course of end-stage renal disease? Well, it prolongs the loss of residual renal function. Those patients who are on dialysis who are still making urine, that's the residual renal function, still making urine. Their kidneys that they were born with, called native kidneys, are still functioning somewhat. And that in all realms, in all studies, suggests that shows that they have a better survival overall. The peritoneal dialysis prolongs that. It offers some patients a better quality of life, and it possibly offers better survival in the early years. And the principle behind peritoneal dialysis as opposed to hemodialysis is that you put the PD fluid in to peritoneal space, it fills, it stays there, and then it dwells in there for, depending on the type of peritoneal dialysis, anywhere from 6 hours to overnight. And it follows the same principles as does hemodialysis, in that the waste products go from the body, and the extra fluid goes from the body into the peritoneal dialysis fluid solution, and that peritoneal solution is then flushed out and drained. Most of the catheters look something like this. Peritoneal dialysis is a good option for some people, and those people particularly include those who work full-time, those who desire autonomy and self-care. They have a good support system, and they have very poor cardiac function. Those are the best candidates for peritoneal dialysis. And the worst candidates for peritoneal dialysis are, you don't have storage space, and this is a picture of a crowded closet. Peritoneal dialysis takes up a lot of space. The PD fluid itself takes up boxes. Patients who have multiple prior abdominal surgeries are poor candidates for this because their peritoneal membrane is scarred, and they can't get the clearance that they would otherwise expect, and those who are unable to make sterile connections. There are many pros and cons for this. I'm going to just point out a few for continuous ambulatory peritoneal dialysis. It's patient-controlled, and there's a flexible schedule. And a lot of people do like the flexible schedule. Other ones don't, because they know that they commit to a certain time slot, they will do it. So that's good and bad. It tends to be painless. They're more mobile when they're on peritoneal dialysis. And actually, there's new data shows that they have fewer fractures because the phosphorus is better controlled. The cons to peritoneal dialysis are that you need space for the supplies. It's relentless. There are no days off. You have to do it every day. If you choose the all-day long type, you're doing it all day, every day. So there's really no descent break. Okay, and the dreaded complications of peritoneal dialysis are peritonitis. The fluid turns cloudy. Sometimes this is a pus in the abdomen. And eventually people lose efficiency with time. Peritoneal dialysis is best for patients who still have some degree of kidney function. And that's what all the studies show. And this shows the survival of, compared to normal, survival of dialysis patients on PD in the blue. And then at year 1, it's better than hemodialysis patients. But at year 5, it's worse than, because they lose the filtering capacity of the membrane. So that's an incentive to maybe start on peritoneal dialysis, but later switch to hemo. And finally, I'm going to talk about home hemodialysis, which is the newest modality. It's up and rising in terms of prevalence, and there are many reasons for that. This is a little bit busy, and so I'm going to just take you through the established best patients candidates for home hemodialysis are those with severe hypertension or left ventricular hypertrophy. Dory this morning showed you that picture of the heart. very thick muscle walls. The problem with that is that when you have thick muscles here, people like that in your arms, like bodybuilders. But if the heart wall muscle is thick, the chamber inside is extremely narrow, which means it cannot store a lot of blood. And so it cannot possibly keep up with the oxygen demands of your body. So those with persistent volume overload and resistant hypertension are good patient candidates for home hemo. And again, the best benefits to home hemodialysis are the flexibility of doing it yourself at home. Blood pressure tends to be better controlled with patients who are doing it daily. Again, it's mostly daily or at nighttime. Left ventricular hypertrophy is diminished, and there's a reduction in phosphate. Quality of life seems to be better. Restless leg seems to be better syndrome, and there are some suggestive studies that fertility is improved. But again, the candidates for home hemodialysis are a certain subset of the dialysis population. And why is there improved parameters on patients with home hemodialysis? Because daily therapy, as you can see in the blue lines here, results in much fewer fluctuations in any of the measures that you can do. You can put fluctuations in blood pressure, you can do fluctuations in body water, the dry weight. You can do fluctuations in potassium, sodium, any of the parameters you plug in. When you're in-center 3 times weekly dialysis, you have large fluctuations, whereas home dialysis or daily therapy is associated with fewer fluctuations. The contraindications to this type of therapy are they lack suitable access, uncontrolled psychoses. Obviously, if they can't take care of themselves, they cannot do dialysis at home, and those who have frequent access repairs. I'm going to skip a little bit ahead for just time's sake, but the most recent study that's being published in the American Journal of Kidney Disease suggests that when you compare a population of dialysis patients for home hemodialysis versus in-center dialysis therapy, the patients in the blue bars are on home dialysis, and this is a percent number here. The number of admissions for cardiovascular events are reduced by about 11% for home hemodialysis patients versus in-center. However, the number of complications for access or infections are increased by about 18%. So there are fewer cardiovascular events, but more commonly access-related events. And you can imagine that if somebody's doing home hemodialysis daily and accessing their fistula daily, they're more prone to having a misadventure. Oh, so finally, okay. So those are in-center hemodialysis, peritoneal dialysis, and home hemodialysis. It's hard to cover dialysis modalities in 25 minutes. I'm going to leave you with the thought that a lot of people are asking the question, with all this technology these days, the cell phones are getting smaller and smaller. The technology is booming around us. Why are we still stuck on in-center hemodialysis with these huge machines? And as a matter of fact, Jonathan Himmelfarb out in the University of Washington at Seattle is just getting ready to pilot a study in patients using wearable technology. And this will be the dialysis. So you're looking at the future of dialysis, I suspect, in some forms. This is a home hemo machine. It weighs about 10 pounds. It's a dialysis machine that you can wear everywhere you go. If you want to dialyze, everywhere you go. The kidney is right here. You can see it's right here. It weighs about 10 pounds. And what was so limiting to dialysis patients that exist currently is that we need a lot of dialysate water, like 60 liters per treatment. That's a lot of water. But this machine, the technology is making it such that with about a pint of water, or half a liter of water that's just being constantly filtered, you can actually get good dialysis. So these are going into clinical trials later this year. So technology is finally catching up to us 20 years later. And I want to leave you with this thought before I introduce Mr. Queen. Despite everything I've told you about the benefits of certain types of modalities, I think this slide sums up beautifully what I hope to you take home today, and that is, regardless of the modality used, whether it be hemodialysis, peritoneal dialysis, or home dialysis, the survival rates for each individual patient are greater for patients who make their own choice or who have a choice. And so if you are currently on dialysis and you choose to stay on in-center dialysis, your mortality rates are greater than the patients. So this is patient choice, only 50% of the patient choice, versus the patient who chooses with the medical team, versus the patients who do what their doctor tells them to do. Now, otherwise, I would say do what your doctor tells you to do. But in this case, that's in jest. But in this case, I want you to take home that those patients who have the choice have the greatest survival advantage of all. And it's probably because they have the autonomy to determine how they want to be treated.